Welcome to the deep dive. Today, we're tackling a really important area in anxiety disorders. We're going to unpack the clinical distinctions, the real practical differences between agoraphobia and specific phobia.
Yeah, these two get confused all the time. So our mission, especially for you, the psychiatry resident listening, is to cut through that confusion. We'll focus on the DSM-5, sure, but really get into the why behind the symptoms and how that drives diagnosis and treatment in your actual practice.
Exactly, and it helps to start with agoraphobia's roots. Briefly, the name comes from Greek fear of the marketplace, but clinically today, it's much broader. It's this really profound dread of situations where escape seems difficult or maybe help wouldn't be available if, panic suddenly hits. And it's not uncommon. Lifetime prevalence is estimated around 2, maybe 3%. So you will see this.
Okay, let's really get into that core mechanism then, because when you have a patient saying they avoid things, the key question isn't just what they avoid, right? It's why. Precisely. With agoraphobia, the fear isn't usually about the bus itself or the shopping mall itself. It's the fear of having a panic attack in that situation. The catastrophic fear of what might happen internally, feeling trapped.
So the place is almost secondary. It's the stage for the feared internal event.
That's a great way to put it. The environment becomes threatening because it limits escape or access to help during a perceived internal crisis.
Hmm.
And the DSM-5 really captures this. It lists specific situations where this fear typically surfaces.
Right, the criteria.
Yes. You need marked fear or anxiety about at least 2 out of 5 specific types of situations.
Okay, what are they?
First, public transportation, so cars, buses, trains, planes, you get the idea. Second, being in open spaces like parking lots, maybe big marketplaces, bridges even.
Okay.
Third, enclosed spaces, stores, theaters, cinemas. Fourth, standing in line or being in a crowd. And fifth, simply being outside of the home alone.
2 out of 5 of those. And there's a duration requirement too, isn't there?
Crucially, yes. This fear, anxiety, or the actual avoidance has to be persistent. We're talking at least 6 months. And very importantly, it must cause clinically significant distress or impairment in social, occupational, or other key areas of functioning. Duration and impairment, got to check those boxes.
Okay, this is where it gets really interesting for diagnosis, distinguishing it from specific phobia. Let's use the classic flying example. How does that help us differentiate?
It's a perfect example because the contrast is so clear. So imagine a patient avoids flying. If the reason is a deep fear of the plane crashing, of turbulence, of something going mechanically wrong with the plane itself.
The fear is external, focused on the situation's inherent danger.
Exactly. That points strongly towards a specific phobia, the situational type.
Mhm.
The fear is about the plane and the act of flying.
Okay,
Versus,
versa.
versus the patient who avoids flying because they're terrified of having a panic attack during the flight. They fear being trapped thousands of feet in the air, unable to escape, unable to get immediate medical help, feeling like they'll lose control or die right there in their seat.
So the fear is internal, the panic attack, and the plane is just the inescapable context.
Precisely. That's the hallmark of agoraphobia. The trigger isn't the plane, it's the vulnerability to panic while on the plane.
That makes sense. What about another common scenario, like public speaking? How do we tease apart agoraphobia from social anxiety disorder there? Someone refuses to give a presentation.
Again, you have to probe the focus of the fear. If they avoid the presentation because they've had panic attacks before in similar situations and they dread that feeling, the racing heart, the dizziness, the feeling of going crazy happening again in front of everyone.
The fear is about the somatic symptoms, the panic itself.
Right. That leans towards agoraphobia, especially if they fear being trapped on stage during it.
Right.
But if they avoid it because they're terrified of being judged negatively, of people thinking they're incompetent, of blushing or stumbling over their words and being humiliated.
The fear is about social evaluation, scrutiny from others.
Correct. That's the core of social anxiety disorder.
Mm.
Understanding that difference is vital because, well, your treatment emphasis will shift.
Absolutely. Okay, let's pivot then to specific phobia itself. We're talking about an intense, persistent fear of a very particular object or situation, right? And people go to extraordinary lengths to avoid it.
Extraordinary lengths is right. That avoidance and the resulting functional impairment are key diagnostic features. Think of someone driving hours out of their way to avoid a bridge, or someone who can't leave their house in summer because they might see a spider.
And there are common types.
Yes, the DSM clusters them. You have the animal type spiders, dogs, insects, natural environment type heights, storms, water, blood injection injury type, which is quite distinct physiologically sometimes, and the situational type, like flying, elevators, enclosed spaces. There's also an other category for things that don't fit neatly.
What about how common they are?
Specific phobias are actually considered the most prevalent anxiety disorder overall, more common than social anxiety or GAD, generally speaking. And there's a notable gender difference. They're diagnosed much more often in women.
Interesting. Anything else epidemiologically important for a resident to know?
Yes, definitely the hereditary component. This seems particularly strong for certain types, especially the blood injection injury phobias. There's often a clear family history.
That's a really key point, the potential genetic link. So, when we're looking at the DSM-5 for specific phobia, what are the nuances we need to catch?
Well, first, the fear response is almost always immediate upon encountering the phobic stimulus or even just anticipating it. Second, and this is critical for diagnosis, the fear or anxiety is judged to be way out of proportion to the actual danger posed by that specific object or situation, considering the cultural context.
Out of proportion. Got it. And how might it look different in kids?
Good point. In children, the fear might not be expressed verbally as anxiety. You might see crying, tantrums, freezing up, or clinging desperately to a parent. So you need to look at the behavior, not just rely on self-report, especially with younger kids.
And like all diagnoses, we need to rule out other possibilities.
Absolutely crucial. The disturbance can't be better explained by symptoms of another mental disorder. We already talked about agoraphobia and social anxiety. But you also need to make sure it isn't, say, fear related to obsessions like in OCD or reminders of a trauma like in PTSD or fear of separation from attachment figures.
Right. But what about non-psychiatric causes? Can phobic-like symptoms sometimes stem from medical issues or substances?
That's a really important differential to keep in mind, yes. While most phobias develop through conditioning or other psychological pathways, you do need to screen for mimics. Acute intoxication with hallucinogens or stimulants, for instance, can definitely cause intense fear states.
Okay, so substance use is one area.
And sometimes, though less commonly, underlying medical conditions can present with anxiety or phobic symptoms. Think about certain neurological conditions like CNS tumors or maybe cerebrovascular issues. The red flag there might be a very sudden onset of a specific fear in someone with absolutely no prior history. Worth keeping on your radar.
Definitely. Okay, let's shift gears to treatment. This is where getting the diagnosis right really pays dividends. Given that agoraphobia often travels with panic disorder, what's the first-line approach pharmacologically?
For agoraphobia, especially when panic attacks are prominent, SSRIs are the go-to first-line medication. You start low, titrate up slowly, partly to avoid those initial activating side effects that the patient might mistake for worsening panic.
And you're looking for a response over several weeks.
Generally, yeah. 6 to 8 weeks typically to see a good therapeutic effect. Now, there's a common pitfall here with medication,
Which is?
benzodiazepines. For acute distress, or maybe to bridge the gap while the SSRI kicks in, short-term use of something like alprazolam or lorazepam can be considered. However, given the core fear in agoraphobia is often about losing control, relying on a rescue pill can be counterproductive long-term.
Risk of dependence, reinforcing avoidance.
Exactly. High risk of dependence, and it doesn't address the underlying cognitive distortions. So benzos should really be short-term, adjunctive, and used very cautiously, never as the sole long-term treatment.
Makes sense. And that focus on internal coping skills leads us right to psychotherapy, right? What are the key behavioral approaches for agoraphobia?
Cognitive behavioral therapy, CBT, is absolutely fundamental. The B part, the behavioral piece, involves graded exposure. You work with the patient to gradually confront the avoided situations,
Step by step.
step by step, often using a hierarchy from least scary to most scary. Alongside this, you're doing the C part, cognitive restructuring, challenging those catastrophic thoughts about panic, helping them reinterpret the physical sensations less fearfully. It's about building coping skills and breaking the avoidance cycle. Systematic desensitization principles often apply here too.
Okay. Now, for specific phobia, where the fear is so object-focused, is the treatment approach different?
It's even more focused on behavioral techniques. For specific phobias, exposure therapy is really the gold standard, the most effective approach by far.
And there are different ways to do exposure.
Yes. 2 main techniques you need to know.
Yeah.
The first is systematic desensitization. This is often gentler. You teach the patient relaxation skills. First, deep breathing, progressive muscle relaxation. Then you expose them to the phobic stimulus incrementally. maybe starting with pictures, then videos, then distance, getting closer, while they use the relaxation techniques to manage the anxiety.
Pairing relaxation with gradual exposure.
Exactly, it's counter-conditioning, teaching the nervous system that the feared object can be present without a massive anxiety response.
Okay, and the second main technique sounds a bit more intense.
It can be. That's flooding. This involves more prolonged and intense exposure to the feared stimulus, either in real life, in vivo, or using vivid imagination, imaginal flooding. The idea is to stay with the fear until it naturally peaks and then starts to decrease on its own through habituation.
So confronting it head on until the anxiety burns out?
Essentially, yes. It can be quicker than systematic desensitization, but requires a very motivated patient and a strong therapeutic relationship because that initial anxiety spike is significant. You have to carefully assess if the patient can tolerate it.
Right. Now, sometimes these phobias are really dug in, maybe part of a bigger picture. Are there other therapies that can help?
Definitely. When exposure isn't enough, or if the phobia seems deeply connected to other issues, we might consider complementary approaches. Insight-oriented psychotherapy can be useful.
How so?
It can help explore potential unconscious meanings or historical roots of the fear, maybe understand underlying conflicts that maintain the phobia. It doesn't replace exposure, but can run alongside it.
Okay, what else?
Supportive therapy is often important, just helping the patient build confidence, reduce the isolation that often comes with severe avoidance. Hypnosis is sometimes used maybe to enhance relaxation or access subconscious fears during exposure.
And family involvement.
Crucial, especially if the phobia is disrupting family life. Family therapy can help educate members, reduce unhelpful enabling behaviors, and build a supportive environment for the patient's recovery efforts. You treat the system.
So bringing it all together for the resident listening, the critical first step seems to be diagnostic precision, really nailing down why the patient is avoiding things.
That is the absolute key because that understanding dictates your treatment plan. Is the avoidance driven by fear of an internal panic catastrophe in an inescapable place? That's agoraphobia, think SSRIs plus CBT, especially graded exposure.
Or is it driven by an intense, disproportionate fear of a specific external thing or situation?
Then it's specific phobia, think primarily behavioral, meaning targeted exposure therapy, either systematic desensitization or flooding, depending on the case.
Excellent summary. So one final thought for you to consider as you head back to the clinic. We talked about that strong hereditary component, particularly for blood injection injury phobias.
Right, the genetic link.
So how might knowing about that potential deep-seated, maybe even biological or familial predisposition influence your choice? Would you lean more towards a purely behavioral here and now exposure approach?
Yeah.
Or might you consider integrating something like insight-oriented therapy earlier on to explore potentially deeper inherited emotional patterns alongside the exposure? Something to mull over.